Hello, thank you for viewing this provider training for the Reverse the Cycle program that's implemented in the emergency department at Cabell Huntington Hospital. Today, I will review with you the Reverse the Cycle model and how it's being implemented at Cabell, and help you understand the role of the provider in one of the components of the model, which is our medication-assisted administration in the emergency department. To give you a little background on why we are here, the Reverse the Cycle model is a comprehensive substance use response model that is designed to work in an emergency department and has been implemented in over 50 hospitals across the nation. As we look at substance use, we recognize that it is a national public health crisis. To understand the importance of having a model like Reverse the Cycle in your emergency department, I'll provide some context and share data on substance use nationally and locally in West Virginia. In 2019, there were approximately 21.6 million people who needed substance use treatment based on their risky behavior, whether that was alcohol use, prescription misuse, or other illicit substance use. However, only 1 in 5 of those Americans were receiving treatment. And for many reasons, people were not receiving treatment because of barriers such as childcare, transportation, and health insurance. But what we find even more so is that many of those people did not think they needed treatment. In the same year, there was over 30 million Americans who had tried an illicit substance in that month. And since then, drug overdose has been the #1 cause of injury-related deaths in the United States. As we shift now to looking at opioid-related emergency department visits, the research indicates that each year we have seen 20 million individuals visiting the emergency department for an illness or injury. And between 15 to 20% of those individuals were identified as having a substance use disorder. For trauma-related visits, this statistic increases from 25% to 50%. This graphic shows us that opioid-related emergency department visits have been on the incline since 2010. Taking a look at West Virginia more closely, opioid-related inpatient stays fell in the highest range nationally. In 2017, West Virginia had a rate of more than 350 opioid-related inpatient stays per 100,000 population. When it comes to drug overdose deaths, according to the CDC, there were over 60,000 drug overdose deaths reported in the United States in 2018. Over 46,000 of those deaths were attributed to opioid overdoses, which is nearly 70%. West Virginia is the highest among the states for opioid overdose deaths. The state had a rate of 51 deaths per 100,000 population in 2018. You can see here in the graph we are showing the increase in overdose fatalities from 1999 to 2018. Taking a look at the blue line first, in the early 2000s, West Virginia saw prescription opioid overdose deaths begin to climb, with periods of decline and incline over the next 18 years. The yellow line is synthetic opioid overdoses, which were relatively low from the early 2000s until 2017, when they began to peak incredibly high, which has a lot to do with the introduction of illicit fentanyl, which has a very high potency. We see synthetic opioids topping out the group of drugs listed here and contributing to 702 deaths. Lastly, with the orange line, which is heroin, we see this drug did not really begin to contribute to a higher level of overdose deaths until 2013. And in 2018, we saw it contribute to nearly 200 deaths. So as I mentioned, the Reverse the Cycle model is a comprehensive substance use response program. Cabell Hospital received funding from the Mosaic Group through an award from the CDC to implement the Reverse the Cycle program in its hospital. There are 3 components of this program. One is screening, brief, and referral to treatment. which is known as SBIRT, the Overdose Survivor Outreach Program, known as OSAP, and then there is the medication-assisted treatment initiation in the emergency department. I'll now walk you through how reverse the cycle will be integrated into your existing workflow in the emergency department. It begins with the universal screening completed by nursing that includes a series of questions used to determine if a patient is at risk for or may have an alcohol or substance use disorder. Any patients identified at risk will meet with a peer recovery coach for a brief intervention. A peer recovery coach is an individual in long-term recovery with lived experience using substances. They utilize their lived experience and their skills that they've learned from motivational interviewing to support patients in making changes to their alcohol or substance use. Some of these changes may include a referral to treatment for in-depth assessment and ongoing care. There is much research shown that supports the effectiveness of SBIRT. It has been shown to reduce healthcare costs. We've seen a reduction in emergency department visits by 20%, reduced hospitalizations by 37%, non-fatal injuries by 33%, car crashes by 50%, and arrests by 46%. Now I will review with you how reverse the cycle will be administered in Cabell's emergency department. The reverse the cycle protocol that has been approved at a system level by leadership at the hospital includes having all emergency department patients ages 18 and older being screened by their nurse during nursing assessment. The screening tools are located in Cerner and include a series of questions used to determine if a patient's risky substance use as it relates to alcohol, prescription drug misuse, and illicit drug use. If a patient scores a 7 or greater on the audit C, which is the tool used to determine risky alcohol use, and/or answers yes to either of the two drug questions asking about a patient's prescription or illicit drug use, they will be considered a positive screen. There are also what we call exclusion criteria that result in a positive screen, which I will share with you on the next slide. If a patient screens positive, the peer recovery coach will receive a notification on their track board indicating there is a patient to be seen. The peer on duty will conduct a brief intervention and develop a plan with the patient. The program is designed to have peer recovery coaches based in the emergency department who will see patients while they're in the hospital. The program includes a community-based peer recovery coach who sees patients that have been identified by nursing as an opioid overdose. The community-based peer coach is responsible for providing intensive outreach and follow-up in the community for patients that have survived an overdose. This visual here shows an overview of the peer recovery coach's workflow. It begins with all patients 18 and older who present to the emergency department, completing a universal substance use screening with the nurse. If the patient screens positive for risky substance use, the peer recovery coach will receive an alert on their track board in Cerner that a patient with risky substance use will need to be seen. The peer recovery coach will review the patient's results on the screening, review their medical history, and the reason for the patient being in the emergency department. The peer recovery coach will then meet with the patient to have a conversation about the patient's substance use. Based on the conversation the peer recovery coach has with the patient, in collaboration, they will make a plan to address the patient's substance use. This plan could be anything from a referral to treatment or a plan to reduce use. Once the peer has spoken with the patient, if they have reported any opioid use, we want to consider them for a dose of buprenorphine in the emergency department if they are motivated to go to treatment. Mosaic has implemented this in hospitals across the nation, as I mentioned, since 2014, and it has been about 4 years since we have been working with hospitals to provide a dose of buprenorphine to patients who are opioid using in the emergency department. There is a great deal of research and science that supports medication-assisted treatment of opioid use disorders and that it does save lives. I'll now share with you some of that research. To begin, a consensus study report in 2019 by the National Academies of Sciences supports that buprenorphine saves lives. We also know that the risk of an opioid overdose death declines immediately when patients with opioid use disorder are initiated with buprenorphine treatment. Medication-assisted treatment has been found to reduce mortality by up to 50%. Both methadone and buprenorphine have been linked to substantially decrease the risk of all-cause deaths and overdose-related deaths. Both medications reduce the number of opioid overdose deaths in the community, and with expanding access to these medications, we do see a reduction in the number of overdose deaths due to opioids. Buprenorphine is also associated with lower rates of other opioid use, improved functioning, decreased injection drug use, reduced HIV transmission, reduced risk of HIV diagnosis, reduced risk of hepatitis C infection, and just overall better quality of life. You may be familiar with the D'Onofrio study out of Yale, where they similarly, in an emergency department, had 3 study groups. One was initiated with buprenorphine and a 3-day prescription with a referral to a primary care provider with continued maintenance and therapy. One group received a brief intervention and then got a referral to treatment with no medication. And the third group received a simple referral to treatment. And what you can see in terms of engagement in treatment at 30 days was their retention and any self-reported illicit opioid use, as well as their toxicology report for opioid use. The group who received buprenorphine in the emergency department with that coordinated link and bridge to care did better across all 3 components. They were retained in treatment at a rate of 78%, much higher than the other 2 groups. Their self-reported illicit opioid use was fewer days, and their urine toxicology negative was at a higher rate than the other 2 groups as well. When we think about practitioners using narcotics to treat opioid addiction, there is a separate registration or waiver needed. The Drug Enforcement Administration has an exception to the registration requirement, which is known as the 3-day rule, which allows practitioners who are not a waivered provider to administer but not prescribe narcotic drugs to patients for the purpose of relieving their acute withdrawal symptoms while a patient's referral to treatment is being arranged. Under this exception, physicians in the emergency department are permitted to administer buprenorphine to patients for no more than 72 hours. So when we think about initiating medication in the emergency department, we know that patients who begin or are already experiencing withdrawal when they're in the emergency department could receive a combination tablet of buprenorphine and naloxone to feel better, allowing them to participate more actively in their healthcare. When patients feel better, which happens almost immediately after receiving the dose, they can understand their discharge instructions better. They are less likely to leave AMA out of a fear of getting sicker. And when they feel better, they're less likely to use an illicit substance overnight before they go to treatment the following day. We also know when patients receive a dose and avoid illicit use, they're more likely to engage in treatment within 24 hours. And when we look across our hospital data, we know that the patients who received a dose of buprenorphine in the emergency department show up at a rate of about 65 to 70% higher. So there is a very high likelihood that they are going to enter treatment the following day. So the way that this component works is the patient has already screened positive and has received a brief intervention from the peer recovery coach. Through that conversation, the peer has determined that the patient's motivated for treatment and they're willing to go to care the next day. Those are really the 2 components the peer is figuring out, that the patient wants to go to treatment and they're willing to go the following day. At that point, the peer recovery coach is going to talk to the provider to let them know the patient is motivated, opioid using, and should be considered for a dose of buprenorphine in the emergency department. The provider is then going to assess the patient for any exclusion criteria and then order the clinical opiate withdrawal scale. The nurse is going to conduct the clinical opiate withdrawal scale, which does exist in Cerner. If the score on the clinical opiate withdrawal scale is 8 or greater, then the provider will order an 8 milligram dose of buprenorphine. The nurse will then administer and observe the patient is taking the medication. And meanwhile, the peer recovery coach is working to coordinate the patient's care for the following day. And I'll go into this in more detail, but those are what we call our fast track providers in the community. These are folks that we have developed specific protocols with so that peer recovery coaches can refer patients to them either the same day or next day for continued induction and maintenance. When a peer recovery coach has recommended the patient be considered for a dose of buprenorphine, there are some exclusionary and cautionary criteria the provider should consider. So we do not want any patients to be on any long-acting opioids for pain. If there is any evidence of liver disease, or if the patient is in any acute psychiatric distress and unable to consent to treatment, then we would not consider them. Or if the patient reports any allergy to buprenorphine or naloxone. We also want providers to proceed with caution, but not exclude the patient entirely if there is any prescribed or illicit benzodiazepine use, or if the patient is pregnant. Neither of these disqualifies the patient, but we do want to make sure you feel confident dosing the patient and proceeding from there. Patients must also meet criteria for a substance use disorder. Highlighted on this slide are the DSM-5 criteria, which you are likely very familiar with, that outlines the criterion for the disorder. Here I have included the MAT order set. When the peer notifies the provider that a patient should be considered for a dose, there is also a trigger that notifies you it is time to consider the patient for any exclusion or cautionary criteria. And there is a MAT order set that you will be able to follow in Cerner. You will see it includes the exclusion and cautionary criteria at the bottom right. As I mentioned, the nursing team will be doing the clinical opiate withdrawal scale. This is a series of 11 questions that the patient can score on, and any score of 8 or higher makes them eligible to receive a dose of buprenorphine. In terms of how buprenorphine works, as you know, there is a ceiling effect, so the patient cannot get high. There is also the naloxone present that blocks the opiate effect if injected. This visual here simply gives us a picture of the empty receptor and shows how perfectly the opioid fits into the receptor. However, with the presence of buprenorphine, if there's any opioid that enters a person's system, the buprenorphine makes the receptor an imperfect fit for the opioid to nestle into the receptor. Patients are being provided with an 8 milligram dose of buprenorphine, and we have not seen a high rate of precipitated withdrawal occur in any of the hospitals where this program has been implemented. But we do know withdrawal is more likely to occur when there is a level of physical dependence that's high, or there has been a short time since the patient's last opioid use, or if the initial dose of buprenorphine is too high. So again, that's why we do the clinical opiate withdrawal scale, to make sure they're far enough into withdrawal that we might prevent precipitated withdrawal, and we look at that exclusionary and cautionary criteria. If the patient happens to go into precipitated withdrawal after you have administered, or the nurse has administered that first dose, we recommend that you give a 4 milligram dose to the patient in addition to that, in order to try and prevent or end their precipitated withdrawal. While the provider and nurse are working on administering the patient's buprenorphine, the peer recovery coach is arranging for the patient to be referred to a fast track provider. Fast track providers are an existing network of community providers Mosaic has worked with that have committed to receiving patients from Cabell's emergency department who have been dosed. These providers are ready and willing to accept patients from the emergency department the same day or next day for continued maintenance. Each fast track provider has a unique protocol that the peer recovery coaches will follow to schedule patients an appointment. The peer recovery coach will not recommend a patient to the provider to be considered for a dose unless the patient has confirmed they will attend treatment and there is likely an available appointment the following day. Should you have any questions, please contact your hospital's Reverse the Cycle champion, Jennifer Peters, or contact Marla Oros with the Mosaic Group. Thank you so much for your time. Have a great day.